All right, so looking at our extensors of the ankles and toes, this is going to be the motion of bringing the toes up. So those are going to be muscles where the tendons attach to the tops to pull the toes up. We've got our tibialis anterior, right, which is that one that's really easy to palpate, right, immediately laterally and attached directly onto the tibia bone. And then, as you were seeing in some of the cross section diagrams you were working with, some of our deeper, our extensor, Digitorum longus and Hallucis longus. I mentioned this with one of the other muscles, but when we're looking at these groups, like on the forearms and on the lower legs, some of our common language is useful. So when you see the word digitorum, it refers to, the digits, right? So either the fingers or the toes. So it's acting on those. And then when we see the word hallucis, it refers to the big toe. So this muscle is going to attach to the big toe. And it's very similar pattern in the lower arm, except instead of hallucis, it's pollicis. So the thumb is pollicis in the hand, and then the fingers are digitorum. So these muscles are all also dorsiflex the ankle. So they dorsiflex the ankle and extend the toes. All right, let's take a look at them in a little detail. All right, so again, comparing their location to muscles around them. We've got, they're deep, they're covered in a lot of places, but you can see where the extensor digitorum, I'm looking at the picture on the right. I'm gonna try to outline in orange. The extensor digitorum is sandwiched between tibialis anterior, and peroneus longus. So I try to outline it in orange, but of course, our tibialis anterior, right, is super easy to palpate. If you feel the tibia and then just go just laterally to it, it's that, long muscle attached right to it all the way. So that's a very easy landmark muscle. And then peroneus longus is also an easy landmark muscle because you can feel the head of the fibula and it goes straight down from there. So really good landmark muscles, and it's sandwiched between those two. But it's also deep, so you kind of just get like slivers of it.
Is that the one with the pes cavus that gets tight and short, maybe? Like the jammed arches and whatnot?
It is, yeah. The ones that are on top are, they are part of, all the ones that go over the top are part of the pes cavus, yeah. Jammed arches, yep. And then going back to this cross section that we all spent time with, B and C are our extensor hallucis longus and digitorum longus. So B is hallucis longus. So it's the one that's kind of deeper and sandwiched right next to tibialis anterior. And then C is, I just did that in orange. And then digitorum longus, C in green, is the more superficial. And it's right between, like we just looked at, the fibularis longus, or in other words, peroneus longus, and tibialis anterior. So we've got our little sandwich right there. And here we're looking at the Synergists of Dorsiflexion. This is all of our dorsiflexors, and you can see, as is true for synergists, they usually are following like very similar pattern, right? Because that means they have the same pull or angle across the joint. So these are all grouped right next to each other. We've got tibialis anterior right here, and our digitorum longus is the one here in the back that attached to all, toes 2, 3, 4, and 5. And then Hallucis longus, the one that's deeper and sandwiched closer to tibialis anterior, goes out to the big toe. And these big long tendons, right, they're covered up with our flexor retinacula. Now, people, their plantar flexion and their plantar flexors are a lot stronger than their dorsiflexors, right? It's part of the design because, we have to be able to, we stand on our toes, our walking, all of that is propelled by our plantar flexion. So it's kind of by design that our plantar flexors are stronger, but sort of also as a result of that, we have a lot of folks with just really tight, plantar flexors. And then a lot of folks get to where they can't dorsiflex as well, and things get really bound up. And so when you're trying to not just, a good approach is to not just release the plantar flexors right on the back, but also work with that relationship of, the antagonist movement, right, of dorsiflexion and plantar flexion. So it's a good idea to work with your dorsiflexors as well. And in fact, one technique is to have the client actively dorsiflex, and that sends a direct signal through the nervous system for the plantar flexors to relax. So you want to work with these dorsiflexors also. We can see our extensor hallucis longus is a very weak inverter, and our extensor digitorum longus is a very weak everter. I've said this before, but on the synergist list, it goes from strongest to weakest. And here we see the action on the toes. And of course, our extensors, they're attaching to the top side of the foot to be able to extend them. Random Zephyr trivia. I had one of these tendons removed surgically to put in my thumb. So I don't have one of these. And the doctor said that, the ones around it would kind of help it. So there's nothing pulling one of them up on my left foot.
So can you extend your toes, all your toes?
When I try to extend all the toes on my left foot, one of them kind of droops a little bit, and the others sort of help it, but not all the way.
Yeah.
I see something in the chat. Let me make sure if it needs to be addressed. Oh, that's interesting. Can we get those twisted and tangled? I'm guessing you're talking about the tendons. They're attached well to where they're attached, so they don't necessarily get tangled, but definitely the fascia can get bound up. And so it can help to do MFR to kind of open up the fascia. All right, so tibialis anterior, we've all been massaging this ever since second week of school with our compression routine. Tibialis anterior, we can feel just lateral to the crest of the tibia, and it follows right along there. It's all very palpable. And let's look at the O, the I, and the A. I see something else in the chat. Oh, yeah, you bet. Okay, so our origin is the lateral condyle of the tibia and the proximal lateral surface of the tibia and interosseous membrane. We've got a good diagram of that. Yes, we do. So, I like these diagrams from your trail guide that show exactly where they attach, because the words don't always really show you like how much of the surface area it attaches to. But this attaches to a big part of the bone of tibialis anterior, and then actually even the interosseous membrane between the tibia and the fibula. So in case you're rusty on what interosseous membrane is, let's kind of refresh that. So the design of our lower leg and lower arms have a lot of parallel, a lot of similarities. And, both on the arm and lower arm and the leg, there's a bigger bone and a smaller bone. And between the two, there's fascia, really deep fascia. So that's what the interosseous membrane is. So between the fibula on the right diagram on the I'm trying to draw color in the interosseous membrane in orange right now. So between the tibia and fibula, very, very deep, there's connective tissue. So this tibialis anterior is using both the bone and the interosseous membrane. Now it's interesting, you can see how deep a lot of these three muscles we're looking at attach. And so one of a very, very common condition that you'll definitely see in your practice at some point are shin splints. And runners get these a lot, but not exclusively runners. And these muscles that attach right to the tibia, and on that it's going to attach right to the periosteum as well as the interosseous membrane. As they're, contracting, they're pulling on that interosseous membrane and on the periosteum. And sometimes that can make little inflammation, irritation, and sometimes even little micro tears. And in a really bad case, it can even pull little chips of the bones off. So working with all these muscles in shin splints is very effective. And they even like pressure like directly into the bone, and even cross fiber friction. Now the thing is, most runners don't like to rest when they're supposed to. And the thing with shin splints is that, they are supposed to decrease their mileage for a while. And that's a hard thing for runners to do.
Do you have any other suggestions for that, Zephyr? I've had periods of that because I used to run. And it's very painful.
Walking backwards is good.
What's that, Trish?
Walking backwards on a treadmill. Sorry, this little puppy keeps barking.
That's all right.
Walking backwards on a treadmill, or just anywhere, and then not falling, you know what I'm saying? Be careful. But you got to walk backwards. It's good for that stuff.
Right. Thank you. Any other physical training recommendations?
Also, you put your backside against a wall, and then you're leaning against the wall. You move your feet away from the wall a little bit, and you straighten your legs, right? So you lock your legs out, and then you try to lift your toes up. Pull your toes to your knees. And you do nice. A couple sets of that to get this muscle here exactly, and the extensor digitorum, and that helps with shin splints too. Like even if you do that before you go running would probably be a good idea. Just a couple of them. Yeah.
Nice, thank you.
Yeah.
That reminds me, what does that remind me of? I used to do a type of yoga called forest yoga. It's not as popular of a yoga modality for some reason, but anyway, they really focused on a lot of the moves, activating the toes and the feet, and really getting that kind of lift on a lot of the poses. Poses that are kind of typical poses like downward dog and everything. There was always like this focus on the activation.
I like it.
Yeah.
Because
Yeah.
the whole thing is it's supposed to like help your knees function better, too.
Yeah. Nice. Uh, of course, this is on the stomach meridian. So working with the stomach meridian, warming up and stretching before the run, decreasing mileage. There's also another technique that's pretty popular in, well, it's not as popular as cupping yet, but another modality that massage therapists have kind of borrowed from physical trainers, physical therapists, and occupational therapists is kinesio taping. And so taking this stretchy kind of kinesio tape and putting it strategically to help rebalance and retrain muscles. So it's not the kind of medical tape where you're trying to immobilize things, but instead you position the tape in a way to help use muscles that are sleepy and calm muscle down that are overactive. So kinesio taping would be another strategy. I've taken several kinesio taping classes from a guy who's really, really good and super experienced. I know all the basics. I haven't gotten opportunity to use it a lot in my practice, but I suppose Jill and I could teach you the basics if you're interested.
Sure.
I'm super interested in that.
Yeah.
Okay.
Because I heard that you can also help with pregnancy through those tapes, holding like the supporting their core.
Oh yeah, that's such a good idea.
Yeah.
And the guy that, sorry.
No. What were you saying?
Oh, I was just going to say that the guy that I studied with is a real big sports medicine guy with a ton of experience in that side. So he didn't really even mention pregnancy applications, but that makes so much sense. That's such a good idea.
Yeah, and I learned some when I did sports medicine. So I was wondering if I could do it to my sister who just told us that she's pregnant. So that's why I was just really interested.
Oh yeah, very cool. My sister-in-law is wanting some right now also, and she recently had a baby and is wanting it more for like a pregnancy-related carpal tunnel syndrome. So I'm gonna bust out my kinesio tape myself.
Ooh, that sounds fun.
Yeah, totally.
Zephyr. So yes. I'm sorry, back to the for Shin Splints, you just said as far as massage, what could help is pressure, like compression and cross fiber friction. Was that?
Yes. Yeah, for some reason, the tibialis anterior and these extensors of the toes, they really like being pressed back down onto their bone. They really respond very well to that. So I would just like really take your time pressing it onto the bone. It's like they do too much like lifting and peeling off. Of course, you could look for trigger points as well, right? Because they could be part of the problem, and myofascial release, right? All of those good things. Yeah, and runners sometimes, because they're the most common folks to get this, and because they really don't like to decrease their running routine, maybe sometimes they could switch up their cardio a little bit and do some different running. They might do well with different shoes. They might do well with maybe their running shoes have gotten old. Maybe they're not changing their running shoes often enough. Maybe they don't have shoes that are the best for, like, if they're overpronator or something. So they could try different running shoes and different surfaces. I don't know if that's the person who spoke up, if that's what you said.
Orthotics.
Yeah, they could do orthotics too. Yeah, and they could change up the surfaces they run on. if they're always running on concrete, right? They could do more trail running, or one of my running friends was always running on a track that, like the street kind of is angled. And if you're always running on the same angle, you're kind of stressing them in a certain way. So, I mean, those are a couple things to do. All right, so our tibialis anterior, we talked about the origin. The insertion is the middle cuneiform and base of the first metatarsal. So on the medial side there. Now, I don't find it too, in my massage practice, I don't find it too helpful to kind of do much right there at the insertion. I find it more helpful to work with the, the origin and the belly of the muscle. And if you can at the, musculotendinous junction, and if you can get a hold of this tendon, you could do a GTO as opposed to working too directly with that attachment. Our actions are inversion of the foot, so the big toe side going up and in, and dorsiflexion of the ankle, right? So the foot going back. All right, and then our extensors, we've got our extensor digitorum longus, which attaches on the lateral condyle of the tibia, proximal anterior shaft of the fibula, and interosseous membrane. So if we take a look at our diagram with relationship to where that is to tibialis anterior, we've got that origin is behind the tibialis anterior origin. And then our insertion is on the middle and distal phalanges of the second through the fifth toes. So just to kind of slow that down in case you're not tracking as fast, the distal phalange is going to be, shouldn't touch that finger, that hurts. The last digit, right, is the distal phalange. I'm showing my fingers, but it's the same on the toes. And then the middle phalange, would be the next phalange up or the next phalange proximal. So the most furthest out on the toes phalange, and then the next one up. So it attaches both of those spots. And right, the big toe is number 1. So then it goes 2, 3, 4, and 5. So all of those together is where it inserts. And we can see, right, it goes under the extensor retinacula. This is very deep in here, but we can feel it more on the distal aspect. Actions, it extends our second through our fifth toes. It dorsiflexes the ankle and everts the foot. So it's a synergist with tibialis anterior on the dorsiflexion of the ankle and eversion of the foot, but it goes further down all the way out to the second through the fourth toes. So it is also an extender of those. Questions on our extensor digitorum longus? All right, Hallucis longus. Again, hallucis means big toe. So this one goes out to the big toe. It's shorter and more distal than our extensor digitorum longus. Looking at the origin, we've got a more distal origin that's right next to tibialis anterior's origin, which is the middle anterior surface of the fibula and interosseous membrane. That's very deep. And it inserts on the distal phalanx of the first toe. So it goes all the way out to the last digit of the big toe. And you'll notice here on the right that its tendon also is covered by retinacula. And so again, I'm going to circle in purple, this kind of region here with the retinacula is a useful area to do myofascial release. So here we have, it's a synergist with the last two muscles, tibialis anterior and extensor digitorum longus. It's a synergist with dorsiflexion and inversion. Oh my goodness, I said that wrong. It's a synergist in the dorsiflexion, but because it goes to the medial side, it's an inverter instead of an everter. Sorry about that. And it also it extends the first toe or the big toe. And you can see it is more distal, so we palpate it or massage it more distally. Any questions on those three? It's kind of a lot today, but I think it'd probably be